All right. Afternoon, everyone. Hey, I don't know if you know this, but this year the Toronto Raptors won. And don't blame me, I didn't do it. I just live in, I got people shaking their heads, coming up twice with this. Drake, who's from Toronto, was pretty excited about the whole thing. I don't know if you watched Drake. He embarrassed me as a Canadian, as a Torontonian, by being all that he was. If you want to be entertained, somebody has put a YouTube compilation together of Drake's emotions during the playoff run, from like elation to sadness. It's like flips in a second. It's like he's like a cyclothymic patient or something. It's really remarkable. So if you want to be entertained, watch a video of Drake going through all the emotions of the NBA championship. And once again, thank you. All right. I have to be honest with you. This is a talk on pre-hospital airway management. What in the actual balls am I doing up here talking about pre-hospital airway management? I am not a pre-hospital physician. I don't have training in it. And I recognize that there is a bit of a political minefield in having this discussion with you. I'm going to give you some thoughts on the literature, and I'm going to give you my perspective on it. But a full disclaimer here is I am not a pre-hospital trained physician. I don't do HEMS work. This is not my area. And so I will humbly submit my thoughts, and then I will receive your very angry feedback afterwards. I know this is a bit of a minefield. There's actually a website that says 5 ways to start an argument with a paramedic. And number 4 is to bring up pre-hospital airway management. And the website says, starting this conversation will activate DEFCON 1 and make us go thermonuclear. So that's a wonderful endorsement from all the paramedics in the room. So I'm, again, quite mindful of where this could potentially be leading to. But I'll do my best. So I think the first thing to do is describe what my pre-hospital system looks like. And I think anytime you're looking at anything in the pre-hospital literature, you have to ask yourself, does my pre-hospital system resemble the one that's being commented on in this particular body of literature? So in Toronto, and in fact in most regions in Canada, we have a non-physician-based pre-hospital system. In our urban center in Toronto, we primarily have 2 tiers of paramedics, BLS medics and ALS medics. BLS medics are confined to doing things like bag valve mask ventilation, chest compressions, and giving a few basic medications. ALS medics can do all of that, plus they can start IVs, plus they can give more drugs, plus they can intubate. And then we have a provincial helicopter EMS system called Orange Air Ambulance. I love this because orange is misspelled, and it's misspelled on purpose, and no, it doesn't stand for anything. They just misspelled orange because that's what they wanted to. Because marketing, I guess, I don't know. But in our pre-hospital helicopter air ambulance service, this is also a predominantly non-physician-based system. And this is staffed by a 3rd tier of paramedics called critical care paramedics. So they can do everything that an ALS medic can do, plus they can give vasoactive drugs, plus they can manage things like aortic balloon pumps. And only very rarely do we have specialized teams get involved in interfacility transports, things like ECMO teams, neonatal teams, but those are the exceptions. So that's the system that I work in. And you may work in a different system. You may have a system with different levels and tiers of training. You may work in a physician-based pre-hospital airway system or a system with nurses that are part of that system. This is not my system. I think the question of pre-hospital airway management is misframed very often. And when I listen to the discussions, this is one of the things that comes to mind. I think it's less really, or should be less, about the specific tool. And it should be about addressing the question of how do you take a patient in the pre-hospital setting and provide adequate oxygenation and ventilation. It's not about do you pass a tube or not, do you bag valve mask ventilate or not, do you use a supraglottic airway. It's about can you oxygenate and ventilate. You're trying to get air in and carbon dioxide out. And really that's it. And we forget sometimes there are some very simple adjuncts in addition to advanced airway management, things like positioning and suctioning that can accomplish that. And really, I think for me, the discussion about pre-hospital airway management involves taking those tools, then putting those tools in the hands of a skilled and trained professional who's familiar with those tools and competent in their use. Notice I said nothing there about their designation, because whether you're a paramedic or a physician or a nurse, to me that matters much less than are you skilled and competent in using those tools. Taking those 2 things and putting them together to deliver timely pre-hospital care, and in this context specifically pre-hospital airway care, that involves getting that patient on into their next stage of care in a timely fashion. That's how the discussion to me should be framed. Not, as a lot of the papers would suggest, do you pass an endotracheal tube or do you not? That's my bias on the discussion. The second thing that comes up, and again, I'm not a pre-hospital doctor, so I can't speak to this in an overly informed fashion, but to me, a lot of the discussion relates to opportunity cost, or as I like to say, cost and opportunity. This comes from a concept that a good friend of mine in Toronto, Andrew Petrosoniak, coined related to the notion of resuscitation economics. And this comes from the notion of behavioral economics, which is if you're doing one thing in a resus, you necessarily cannot be doing something else. And so a lot of the interest around do you intubate versus do you use the supraglottic airway is really just a matter of resource utilization and efficiency. Not so much is an endotracheal tube better or worse, but is it more efficient given all the other complexities of pre-hospital resuscitation to use something like a supraglottic airway in its place. And to me, that is the more relevant question. What is the most time-efficient and resource-efficient tool in the hands of a skilled provider in order to provide timely care? That being said, there have been two papers in the past few years that have made a fairly big splash in the area of pre-hospital airway management. The first is the Airways 2 trial. And so this was a study that looked at second-generation supraglottic airways versus endotracheal intubation in pre-hospital airway management in 4 centers in the UK. This was a big study, involved close to 4,000 patients per arm, and they were randomized in a fairly effective and complex way. I'm not going to describe it in too great a detail. The comparison was a second-generation supraglottic airway, and this is what you're seeing on the left is called an iGel. So this is a supraglottic airway that doesn't involve air in the cuff. You just insert it and start using it, versus an endotracheal tube as the primary airway management strategy. And again, if you're going to critically appraise this literature, ask yourself if the airway management process that they used in this study really reflects what you would do in your system. So here, it was only direct laryngoscopy. Video laryngoscopy was not used. And as far as I can tell, these were not drug-assisted intubations. And so that was the comparison. The bottom line in this study was the effect, their primary outcome of interest was the effect on intact survival at 30 days, which is an outcome of interest for all of us, I think, using a modified Rankin score. And the bottom line is there was no difference in those two strategies at all. So the authors concluded that at the very least, these two strategies of a supraglottic airway versus an endotracheal tube could be considered relatively equivalent. They didn't use the word equivalent, but they're relatively equivalent when it comes to their use in cardiac arrest. Interestingly enough, the one, I think, important difference was the frequency of initial ventilatory success. You were much more likely to have effective ventilation parameters with a supraglottic airway. I don't know what that means, and it didn't seem to have a big effect on outcomes, but to me, that's a clinically relevant outcome, that you were ventilating these patients more effectively on your first attempt with a supraglottic airway as compared to an endotracheal tube. The second paper, published in that very issue of JAMA, as if they planned it that way, was the PART trial. And the PART trial is a little bit different, in particular because they were looking at airway strategies, not necessarily airway techniques, and their outcome of interest was different. So in the PART trial, they were looking at laryngeal tubes as a different tool, different technique versus intubation, not quite versus intubation. I'll get into that in a sec. And they were interested in mortality at 72 hours, which is a popular critique of this particular study because you could argue that 72 hours in terms of mortality is not a terribly patient or resource-focused outcome of interest. Nevertheless, this is what the study looked at. And they looked at a slightly different tool. So recall the Airways 2 trial was looking at second-generation supraglottic airways. In this study, they looked at the laryngeal tube, is what's pictured on the left, as compared to an endotracheal tube. In this study, the intubation attempts were different from the prior. They were different from Airways. In this study, video laryngoscopy was allowed. Paralytics were given. So again, somewhat different system in terms of the initial tools available for the airway approach. And again, the authors of the PART trial are very quick to point out that this study is not necessarily about intubation versus a supraglottic airway. They looked at a supraglottic or laryngeal tube first strategy. This was the pragmatic part about the pragmatic study. In other words, you could choose or were randomized to a laryngeal tube as your first approach, but the operators got to choose what they did subsequently. So it was a strategy that emphasized laryngeal tube first, but not necessarily a comparison of a laryngeal tube versus an endotracheal tube. And again, they were looking at mortality at 72 hours. In this study, they did find a difference. This difference at 72 hours was found to be statistically significant, leading the authors to conclude that there was a small but significant effect on mortality in a strategy that emphasized laryngeal tube as your first approach. What I think is really interesting, though, and the authors really didn't explain or didn't have an explanation for why this was the first pass intubation success was really, really low, much lower by comparison to what we'd be used to seeing in the literature. And I don't know what effect that had on the outcomes, but it's quite different from the 90% or so that we're used to seeing in the pre-hospital setting. And then finally, just this past year in BMJ, this was a large matched cohort study looking at supraglottic airways versus endotracheal tubes as the primary airway approach in out-of-hospital cardiac arrest. They found that overall there was no difference in mortality except in patients with non-shockable rhythms, in which case there was an effect favoring supraglottic airway use. And I think that's interesting, because think of what you're not doing in somebody who's got PEA or a non-shockable rhythm as their primary arrest. You're not defibrillating. You're not delivering electricity, which comes back to this notion of opportunity cost. Could it be that an LMA is not necessarily better in PEA, it's just that it's not getting in the way of other things that are more important, like defibrillation? And maybe the effect is that when you're you're making an intubation attempt in a shockable rhythm, you're actually delaying the timely provision of electrical therapy. I don't really know, but I think it's interesting for hypothesis generation. And then to conclude, we've talked about medical cardiac arrest almost exclusively. Trauma patients are something different. So intubation in the pre-hospital setting in trauma patients often gets justified, I think, by the notion of protecting the patient's airway. And as a preeminent pre-hospital physician, Mike Abernethy, has said, protect it from what? You really have to think hard about what it is you are actually protecting that patient's airway from. In pre-hospital trauma arrest and in patients who are in pre-arrest, I think intubation could actually be extremely detrimental, and the process should favor early transport. This is particularly true in patients who have head injuries. A while back in Ontario, in the province where I live, there was this massive pre-hospital trial called the Opal Study. And what that looked at was the optimization of an ALS program in the pre-hospital setting throughout Ontario in the 4 years before and the 4 years after the implementation of an ALS system. So they looked at all outcomes in the 4 years leading up to implementing an ALS pre-hospital system in 17 districts in Ontario. And then they looked at all the outcomes 4 years after. And to this day, this study was done in the 90s, but to this day it remains an incredibly controversial study, because the predominant result from that study in cardiac arrest, in cardiac patients and in respiratory patients, was essentially a nil effect, that adding ALS to BLS care translated no benefit. But in trauma patients, particularly in head-injured trauma patients, there seemed to be effect towards increased mortality in patients with severe head injuries who are intubated in the field. Now, this is in contradistinction to other papers that have suggested a benefit. There's a bit of a mixed bag here, but there is some signal suggesting that severely head-injured patients probably shouldn't be intubated in the field. Perhaps that's better done in hospital in a more controlled environment where you have more medications available to you. But of course, that's extremely situation-specific. So to summarize, this discussion comes down, in my mind, to really three things: the who, the when, and the how of pre-hospital airway management. The who, honestly, I don't care what your designation is. What matters to me is your skill set and your familiarity with the tools that you're using. If you're competent and skilled and familiar with the tools that you use, that is invariably more important than the specific technique that's chosen. The when, again, I think in trauma patients, it's a different story. In sick trauma patients, in head-injured trauma patients, this may be better done in hospital. In medical cardiac arrest, it's a somewhat different discussion. Whoops, sorry. Oh, I gave away my W joke there. And then the how. If I can summarize the supraglottic airway discussion, it seems to be that there is a mortality benefit at 72 hours when talking about a laryngeal tube versus intubation, and perhaps no real difference at 30 days in terms of neurologically intact survival when you look at second-generation supraglottic devices like the iGel. But that's probably the best we can say for the time being. This is the social media discussion to follow. So I look forward to seeing that. Thank you very much.